course, in the routine coronary intervention. And many times there is no availability or cost issues are there in India when they are doing rotational atherectomy, increasing the time of procedure, and those people try to do a balloon, cutting balloon, and all those things, and sometimes they fail. And they fail, and if of course, what would be the choice? Rotational atherectomy versus IVL, number one, and of course IVL is better as compared to data as shown. But again, the cost in India of IVL is about 3 times as compared to rotational atherectomy, and that becomes again a sort of a hindrance in using it. I wanted to know, especially about this thing, this was my comment, that low profile, newer devices are coming. IVL are still in the pipeline or not? Because many times you can't use, because of a high bulky device, you cannot use IVL. So Ramesh, are you aware of some devices which are coming up?
Yeah, Dr. Sharma mentioned about that laser type of technology that will be actually
But it's available in the US or no?
Starting clinical trial, not available yet. And even in the US, the Rota is 1/3 the price of an IVL balloon. And still many people, if it is uncrossable lesion, you have to depend upon that.
I was happily surprised. He said 10% of his volume is about calcific, and he used one of the devices. What about your center? Because we are using about 3 to 4% approximately.
So, I mean, obviously, we're all, these are quaternary centers, our center out of 10 cath labs. All the calcified lesions that need debulking come to our center. All the other 9, when you talk about IVL, I made sure that all the other 9 sites have IVL first, because they don't have, except one other site, 8 centers don't have cardiac surgery backup. So they need to get some sort of atherectomy device first, and if they fail, then they come to us. And those patients, obviously, it's uncrossable or undilatable lesions. We depend upon IVL or Rota or orbital atherectomy.
And one small message I want to give, and you'll agree with me, that don't do post-dilatation, especially if you have a nodule. Don't do too much of dilatation, over dilatation, because you will end up with problems and perforations. So don't try to be cosmetically best result. Try to find if the stent is well opposed by imaging or otherwise by stent boost. Don't do too much, especially young cardiologists. So sometimes they try to have a maximum best dilatation, best picture, or more of a cosmetic picture. But try to avoid a huge post dilatation, especially in calcified lesions. Thank you.
And also don't stent until you do proper debulking.
Yeah, that's it. Thank you.
My question about pulmonary embolism. I want to understand the